built the plan. We decided on the premiums, the structure, the benefits. Then we issued employees cards with the company name as their new insurance provider. Walked them through how to deal with, whatever challenges they might face as they sought care, what might happen if they got a balance bill. Did a lot of education, and that was it.
And basically, you went from being fully insured to being self-funded, correct?
Correct.
And it's important to understand the premise, because I don't want anyone listening to this to think, oh, I'll just go self-insured and I'll be all set. If you're fully insured with Blue Cross and Blue Shield and you go self-insured with Blue Cross and Blue Shield, you're going to get the same results, because the majority of costs, which are your medical care set by the network, same network, whether you're fully insured or self-insured. Your pharmacy costs set by the PBM, same PBM, whether you're fully insured or self-insured. So what I need employers to understand is the amount of money you have to put into an insurance plan, no matter what it is. That's your premiums, your copays, your deductibles, so on. That is a direct result of the vacuum left by the money coming out of the plan. So the only way to solve this, and we've trained employers poorly for decades, my industry, we've trained employers not only that the carriers are basically all the same, but we've trained them even that we're going to bring in the same rates. So don't even judge us based on how we can control your healthcare costs. Judge us based on all these other things that we throw in for free, HR, technology, compliance, whatever. Not a single client of mine looked forward to my average annual renewal meeting because I'm bringing in varying degrees of bad news. But that wasn't what caused me to pivot. What caused me to pivot was the meeting a few weeks later when I met with their employees. And I had this realization one day, and it was actually at a doctor's office that was a client of mine, an ophthalmologist's office. The doctors were all making $500,000-$600,000, but their staff is making $35,000-$45,000. And I was bringing in a plan that had a $5,000 out of pocket. And I said to myself, other than the doctors, there's not a single person in this crowd that can afford that. I must be instilling the fear of God to get sick in these people. Here I am selling insurance, and most of America is definitely won't ever lower costs. And it boggles my mind that I have to convince employers of this when they've had 20 or 30 years of costs going up. Like, what do you think is going to happen all of a sudden? Just magic's going to occur. So the plans that we build, what differentiates them is we remove those perverse incentives. And look, it comes with some friction, but it also comes with a lot of benefits. For example, the average employer spends a lot less money. I want to give just a couple of metrics on Greg's company, Archer Point. When they came to us, we look at per employee per year. So we look at total amount they spent over a year, and then we divide that by the average number of employees enrolled. So this is a blend of singles and families and employees, and spouses and children. But if you take the total they were spending in United Healthcare divided by the number of employees, they were at $16,620 per employee per year, which, by the way, is right almost dead in line with national average. As of this past year, they're a February 1 renewal. So I'm looking at last February 1 to this past January 1. They were at $74.55 per employee per year. So a little less than half. And at the same time, the members have opportunities to get prescriptions and procedures and imaging with zero out of pocket. So I want to be clear, this doesn't come with them having to pay more. As a matter of fact, they had a couple of HSA compatible plans, and we had to get rid of them because we had to make the plans richer because the IRS does not permit us to waive out of pockets in an HSA compatible plan.
Remember, one of the things that I love to ask CEOs when I get in front of a group of visited CEOs is, why do you buy healthcare? And what I normally hear is, what do you mean? It's because I have to. It's a bilateral decision. I either do it or I don't. And yet, when I ask you to really think about it, you tell me, well, I really do it to attract and retain top talent. I do it because I want to create a healthy, productive workforce, because my customers are happier when my employees are healthy and productive. I do it because I want my employees happy with me. And I wish they were more affordable. And so we talk about, okay, well, if that's what you want, who have you aligned to work to help you get that? And almost every CEO I talk to is like, nothing.
So if United Healthcare, let's say, is making an extra $1,000 on that drug every time it's filled, which is not uncommon, and I ask them to remove the drug from the list of covered drugs so I can get it for free, I've asked, they're going to tell me, go pound sand. But our PBMs don't make money that way. So what we were able to do was we were able to, of course, make sure that the member has the medication, right? We don't want them going on medication. So they fill it once at the pharmacy, we pay that $4,000 fine. And then we remove it from the formulary. Now we have a person that walks them through the assistance program because these manufacturers don't like giving expensive drugs away for free. So they don't make it easy. That's why we have an expert in it. Then we applied for that program. And now the manufacturer of Ozempic is sending that drug to that member every month for no cost to the member and no cost to the health plan at all. We've done this with $1.2 million hemophiliac drugs. The pain point that employers are feeling, whether they realize it or not, is a combination of two things. You have the really high cost utilizers that are the small percent, but using up a big percent of dollars. And we have ways to attack it, whether it's cancer care or dialysis or medications. But there's this other neglected group. It's so easy to focus on the 2%. But you have this other group of people that are continually going down in clinical state because they're unable to take care of themselves. They're not taking their $3 atorvastatin, okay? They're not checking their blood sugars regularly because they don't know what the cost is going to be when they go to the endocrinologist. Their test supplies, their glucometer supplies are too expensive. We get this one for not only like $40, but it's a cartridge you just put in. You just stick your finger on it like this. It pricks it, it draws the blood, it shows you the reading in one motion. You don't need different lancets, you don't need alcohol swabs. And then it sends the results to your doctor electronically. And we say to members, if you use this and you use it as your doctor prescribes 3 times a day, whatever it is, we'll cover all the supplies. Your plan will pay for 100% of the of nothing. So we've got to make the right care as accessible, as affordable as possible, and remove all those middlemen who not only add multiple layers, but put pressure for costs to go up. I think the biggest thing that Greg did is he recognized that he's in the healthcare business. He didn't want to be, he didn't plan to be. But you know, when something's 2, 3, or 4 on your P&L, you're in that business. And listen, I'm not the only guy in the country doing this. There's not a lot. We're not the majority, but I'm not the only one. But if I could give an employer any advice, it's this. Discounts mean nothing. Don't have someone come in and say, we have bigger discounts on drugs, bigger discounts on medical care, use this network, it's bigger discounts. The discounts don't mean anything because the starting price is not contractually obligated, nor is it consistent. So literally it means nothing. And if you don't speak to someone that you can demonstrate to you, I'm talking line item by line item. Here's how much you spent on a knee surgery last year for one of your employees. Here's how much it could have cost. Here's how much your drugs are costing on a drug by drug, not overall, not you're getting a 40% discount, I can get you 45. No, dollar for dollar, this drug was costing this before, it's gonna cost this now. If they can't demonstrate to you that they can actually lower the cost of care, if they can't demonstrate to you that they can create a benefit structure that incentivizes stupid things. Let me give you an example, okay? And I'm gonna tell you about another perverse incentive in our healthcare system. It's how doctors are compensated. You see, doctors are paid in a way for costs to go up. One of the dirty secrets of compensation of doctors is something known as an RVU, which stands for relative value unit. And it's a measurement, and you know, running hospitals, you have to pay doctors RVUs. They expect to be paid RVUs. But an RVU is a measurement of how much money they're helping generate in other parts of the healthcare system. So the more money I generate over there, the more money I get paid here. So if I'm an orthopod and Greg comes into me because his hip is hurting him, and I want to do an MRI, common everyday scenario, happens hundreds, thousands, millions of times a year. I am most incentivized to send him to the hospital-based MRI that's going to cost $4,000 or $5,000 or $6,000 because that's going to maximize my RVU. But one of the things that we've done is we've developed direct contracts with independent imaging centers across the country, thousands of them. And our average price for that same MRI on the same machine is $400 to $600. So if one of your employees goes, let's say they have a $3,000 out of pocket and they go for a $6,000 MRI, they pay $3,000, the plan pays $3,000. But instead we intercede and we say, hey, instead of going there, if you go over here, your employer will pay 100% of the cost. Because guys, we've had consumer-driven healthcare for 15 years now. When you give employees more skin in the game, but you don't give them cost and quality before services are rendered, then the skin in the game is a barrier to getting any care. It is not an incentive to getting good care.
People don't know that the CAT scan at the hospital is going to cost $3,000, and that the very same machine at the outpatient imaging is $300. They don't know that. All they know is that their doctor said, you need a CAT scan. And I'm going to make an appointment for you on Wednesday, and you're going to show up at the hospital at 8 o'clock, and this is how much your insurance is going to pay, and this is how much you're going to pay. They have no clue that there's another option, that the same insurance company that's covering has contracted for the same procedure $300 over at the imaging center. It's like, why isn't the insurance company wanting to get involved? Why wouldn't the insurance say, no, don't go to the hospital and pay $3,000. That's our contract with the hospital. Because they make more money the more they spend. It's that misalignment of incentives.
Insurance is meant to cover those events, those infrequent severe events. We expect health insurance to do that, the cancers, the heart attacks, but we've come to also expect it to cover the frequent, not severe events, the strep throat, the annual physical. And take healthcare out of the mix. Insurance as a financial vehicle does not sustain itself when it's covering both of those things. The other problem that we have is, I'm sure there's a lot of people on this call who 20 or 30 years ago, they went to their primary care physician. And when they were meeting with the doctor, they were also meeting with the owner of the practice. And then at some point, they go for their next annual physical, and now the logo of the local health system is on the front door. Now, I'm going to tell you an interesting statistic. Most primary care offices nowadays lose money. It's one of the reasons they sell to these large health systems. Why is the health system buying them if they're losing money? Well, primary care has become the milk at the back of the store. They're the loss leader. They get you in the door, and then they incentivize them through RVUs and one other metric, patient volume. They have to see 20, 30, 40 patients a day. And of course, the more patients they see in a day, the less time they spend per patient. And so they've become a referral machine to churn and burn that patient. And if you come in with a back pain and you wind up at the back surgeon, you've preordained back surgery being the most likely outcome. So, but doctors, primary care doctors, have to do that volume, even if they're still independent. The carriers have depressed their reimbursement rates to where they have to provide a huge volume of care, whether it's necessary or unnecessary. And I want you guys to know that, first of all, collectively, the 5 big carriers in the first quarter of this year made $60.8 billion of profit. And in most cases, especially with United Healthcare, if you invested in United Healthcare, most time periods you would have done better with United Healthcare than with Bitcoin. So
wow,
what does that say?
Yeah. So we're almost out of time. Greg, is there anything that you would like to share in closing from your experience to other CEOs about this journey you've had?
Yeah, I'd say probably one of the things we did, which has really helped us with friction after the first year, is we did implement a network for physician and ancillary. So we worked with David to implement the PHCS, or wait, sorry.
You got it,
PHCS, yeah, multi-plan. And that our abrasion rate went from about 5.5% down to 1.5%. And so that really helped us. And then we'll continue to explore with David other models to continue to improve the plan.
And
I'd say if there's anything,
explain what that is, just so that people understand.
Well, so when we first implemented the plan, you could go anywhere, which meant we had no network, but then that often, at least initially, created access issues where somebody would try to go get care and it'd take some effort on their part to get set up in the billing system of whatever provider they were going to. Once we put in a network where you can still go anywhere you want, but if you go in the PHCS network, well, that's already set. So our employee doesn't have to worry about access or getting, set up with our insurance or anything else.